everybody. I would like to thank PMS and AstraZeneca for inviting me to deliver this talk. Actually, I have never been to this beautiful place before. I do have a lot of friends working in this hospital, but I'm sure I'll have time to go around and see your beautiful hospital and the setting. Today, I'll be talking about something regarding diabetes, but it will be a little bit different from the usual talks which we gave with a lot of slides and pictures. There will be some scientific data at the back at the end of the presentation, but we'll be looking at ACE. ACE is not the usual ACE inhibitor. It is linked to adherence, compliance, and efficacy. It is the biggest problem in type 2 diabetes. With any chronic problem, these are and the actual control of the type 2 diabetes depends on these ACE factors. And these are the different modules we'll be going through. We'll start off with the first module, which is patient adherence and compliance. Now, what is compliance? Compliance is the extent to which a patient acts in accordance with prescribed intervals and dosing of and the dose of dosing regimens. So, if the patient is fully compliant, this is the type of graph you'll get. That means the patient has been taking his medication regularly, and he is fully compliant for 12 months. What is persistence? Persistence means accumulation of time from initiation to discontinuation. That means the patient, whether he has been taking his medication on a regular basis or not. So it is fully persistent. These two graphs will look the same. So how do we distinguish the two? So this is an example of a patient is partially compliant. So this is on, off, on, off. So this one, on here. You can hear me? Can you hear me at the back?
Come in front. Were you sitting in the back? You could be come in front.
It's on for us. It's on and
सामने आ जाओ ना।
सामने आ जाओ।
फोन मना किया है। अरे विजय। Yes, yes.
आ गया? आ जाओ।
Okay, so if he is partly compliant, so we have this sort of phenomenon.
Pointer.
So partly compliant means keeps going on his medication. Non-persistent means he's been taking it for regularly for some time, and then at some stage he drops off. This is non-compliant and non-persistent, and this is not acceptance, which is very common. The patient actually does not take at all 100% whatever medicine. So the control of a chronic problem will actually is decided by the patient himself, not by you. We can write whatever we want, but it is the patient who decides whether he wants to take his medication or not. And we will see what are the reasons why he is doing that. What is the importance of this compliance? If you have high compliance, your hospital admission is very low. Compared to the more your non-compliance goes up, your hospital admission. So this is related to complications. Okay. This is for any infection. So medication non-compliance, as we mentioned, reduces the effectiveness of pharmaceutical treatment, and on an average, 1/3 to half of your patients are non-compliant with the medication. Now, this is the problem, as you mentioned. The hardest thing about taking care of people with diabetes is the failure to follow diet and exercise patterns, failure to comply to take sugars regularly. I always tell my patients, this illness is treated by monitoring. If you do not monitor your sugars, you can never control them. And obviously, we are looking at this failure to take medication. And 95% of the patients' diabetic care is done by the patients, and the health professionals have little control of it. So it is your patient who actually does all the job. I always tell my patients, if your sugar is controlled, it is your credit, not mine. If it is uncontrolled, it is your discredit, not mine. Because we can advise you, but actually at the end of the day, when you're going to comply with those, depends on patient. It comes mainly through education. Okay, might be other factors that the medicine might be expensive. Of course, not in your hospital because all the medicines I think they are provided free of cost. So that should not be a reason for non-compliance. But when we go out in the practice, this is the biggest problem. So other big problem with type 2 diabetes is that it's a progressive disease. We know that the beta cells every year is gradually getting destroyed. So apoptosis of the beta cells takes place. It's a multi-systemic disease with comorbidity. So we have polypharmacy. So we have a lot of medication, 3, 4, 5 types of medication that get confused what to take when. And we have complex guidelines, so a lot of people will get. So poor compliance is expected in 1/3 to half of your patient, irrespective of the disease, prognosis or setting. So treatment complexity. So we make the treatment very complex. So that interferes with the patient compliance. And this is an example of this is that if the patient is asked to take a medication once a day, his compliance rate is much higher. So non-compliance is less. If you ask him to take 4 times a day, his non-compliance rate is much. So we are now going for medications which are once a day, combination medications which work for a full 24 hours to reduce your the non-compliance rate. So best compliance you can see is once a day. And this is with sulfonylurea. As you can see, over a period of 1 year or 2 years, over a period of 1 year, 2/3 of your patients are compliant. Whereas once you come to 2 years, you start getting deaths. What is the importance of compliance in diabetes outcome? If you have good compliance, you have uncontrolled sugar, that means you're fasting more than 110, is less than 20%. Whereas if you're poorly compliant, majority of the time, fasting sugars are more than 110. That's not a way we can do it. That was done from a questionnaire for patients between 30 and 75. So the patient adherence is a challenge. Okay, the fact that so many patients do not adhere to these becomes a problem. So adherence is a big problem, and we cannot control it. And compliance and complications are all related to these. What are the barriers to medication? This was done in a survey that those who had uncontrolled diabetes, more than 9% HbA1c. Okay, the barriers were 1/3 of these patients were paying for the medication. They found it expensive, so they could not afford to buy the medications. Remembering the doses was a big problem. Reading the prescription labels, if your handwriting is not, or whatever is written on the bottle, he cannot understand. So that is another reason he cannot take it. So remember, I think in your hospital you must have computers, so you can give a computer printout to the patient. Sometimes you might even write in your mother tongue, maybe Bengali or Hindi, to explain it to the patient. Or obtaining refills, that means getting repeat prescriptions. Okay, the medicine finishes and they cannot go to the shop to buy them, or they don't come to you to get a repeat prescription. So medicine is missed out because of this. So taking more than 2 doses of anti-diabetic medication was associated with significantly higher HbA1c. So you have to make it very simple for the patients. Again, the side effects of the medications, forgetting to take the medication was a big problem, and this is an Indian study. As you can see, about more than 3/4 of the patients, side effects more than 3/4. Okay? There are other things also like whether it's expensive, feeling ill, okay, side effects, things like that. So these are multiple factors. So we need to have therapies which will give lower side effects and simplified regimes. So make it very simple to the patient to remember, and we have long duration of action, 24 hours. So as you can see, if you have, what is the relation between HbA1c and dose frequency? So once a day, and 3 times a day. Once a day. So once a day, so lower dose frequency was associated with a better metabolic control. And this is retrospective study. This is found in the done abroad in the community pharmacy, because as you can see that as initial years the compliance goes up, as the years go down, they go down and plateau out. That means they are all on an average after 3 to 10 years, only 50% compliant with your medication. So in summary, with patient compliance or adherence to agreed management plan is a major challenge. Taking in more than 2 doses of antidiabetic medication daily is proven to be significantly associated with non-compliance, non-adherence, leading to higher HbA1c. So what is the role of combination therapy? Okay, previous guidelines tell us start with metformin, then you wait, it's uncontrolled, then you keep on adding. But nowadays, we are going for a different type of approach. This was a classical approach. You got it down, then waited for it to come uncontrolled, then keep adding at these stages. So these are the points that we have potential changes. That means, and there is your HbA1c goal, and you never got to that goal. So nowadays, what are we doing? We want to keep it down there and keep it down there. So this is not possible with a single drug. Remember that. Majority of the time, we need a combination drug, at least 2 drugs to bring it down and keep it there. And when we add drugs here, as soon as it goes beyond maybe 7.2, 7.3, to keep it all down at 7. So the complexities of getting patients to goal, as Rationale for earlier combination mentioned, that percent of patients with type 2 diabetes getting to goal is far from optimal. Conventional treatment has been characterized, as we mentioned, by treatment failure rather than treatment to success. And use of combination therapy early in the type of disease is more effective reaching, and this is important thing, maintaining. Reaching the goal is not always difficult. It is keeping it down, maintaining it at the goal is even more difficult, as you know, because diabetes is a continuous process. The beta cells are continuously undergoing apoptosis. So you need to keep adding drugs every now and then, increasing the dose of drugs so that you can keep them at the target level all the time. So what is the outcome? The outcome of this is complication. If you're not adherent, non-compliant, do not control their blood sugars, you have complication, and that is what we worry. So this is a slide which shows that if the patients are adherent, their mortality is less than non-adherent patients. Anything you look at, all-cause hospital, back pressure, diastolic, LDL, glycogen hemoglobin, is better in compliant patients than in non-compliant patients. So all the parameters are better. This is a study where they showed that they looked at retrospective records of the database of more than 5 lakh patients over a 12-month period. Okay, those who are 18 and above, and they found that you can see hospital admission less in adherent patients with or without complications. All-cause mortality in diabetic related, again with or without complication, less in adherent patients than in non-adherent patients. Emergency room admission visits, that means coming with complications to the admission room with without complication, less in adherent patients than in non-adherent patients, whether it's in diabetes or non-diabetes. The patient compliance and presence of complications, this study was done to investigate the duration of the disease, association of disease duration with the onset of complications, and the physician assessment of the patient's compliance. The physician estimated that a good compliance was established in only half of these patients, and the number of complicated diabetes increased proportionally with the length of the disease, while the number of complications was lower in cases with better patient compliance. So this study was found that, and you found that in all countries, whether it's China, Europe, or US, only less than 2/3 of your patients will actually, 2/3 of your patients actually do not achieve their targets. Only 1/3 of your patients achieve the targets. And as you can see, HbA1c is related to mortality. So higher HbA1c, your mortality goes up. So that is why this is related to mortality. So the key messages in this set of slides is that lack of compliance and adherence is a common problem, leads to morbidity and mortality. Okay, and we need, for chronic disorders, we need to stress a lifestyle, complex treatment regime should be avoided. We should have simple dosing, preferably once a day dosing. The other problem which prevents you from getting them to goal, what is the biggest problem in a type 2 diabetic you want to get them to goal? Is hypoglycemia. That is where you will get stuck. You will get hypoglycemia and you stop taking his medication, you will have to reduce the dose, his HbA1c will never get controlled. Therefore, remember, And other problem is weight gain. So these are the two biggest problems in type 2 diabetic patients when you want to give them to target. And all the drugs which are going to come into the market in the next 10 years will address these two major issues. If you look at the linagliptin and the DP4, they've all come in with no hypoglycemia and very minimal weight gain. The GLP-1 analogs are all going to produce weight loss. The SGLT2 inhibitors will going to come in the market in the next few years. They will cause weight loss, no hypoglycemia. So biggest main thing all these new drugs will have is little or no hypoglycemia and no weight gain, if possible, weight loss. So that is why all these drugs are so popular now, because it does not interfere with the lifestyle of the patient. So hypoglycemia, as you know, is very important. It affects the patient's life. It reduces the quality of life, reduces treatment satisfaction, reduces adherence, okay, and more common, as you know, at your target. The closer you get to your target, the more hypoglycemia the patient will get with conventional medication. What is the problem with hypoglycemia? There are economic factors, that he loses work, so productivity is lost, psychological fear of hypoglycemia. They do what they call defensive snacking. He knows that every day at 1 o'clock I'm going to get hypoglycemia. So 12 o'clock he starts eating every day to avoid that hypoglycemia. And what is the result? He overeats. He puts on weight. So this is the biggest problem with defensive snacking. Then you have out-of-pocket expenses because he might get unemployed because of these problems. Indirect costs are also important. And as you mentioned, these are the direct costs, these are the indirect costs involved. And average cost of hypoglycemia, if you do it in the European countries, we do not have the figures for India, is 530 to 680 euros per episode of hypoglycemia. Whether he needs to go into the hospital, whether he needs to check it at home, whether he needs assistance, because he needs to check his sugar more frequently when he gets an acute attack of hypoglycemia. So hypoglycemia should be avoided at any cost, and this is the cost, as you can mention, per hypoglycemic event, particularly if they go into the hospital with sulfonylurea and insulin, which are the two main causes of hypoglycemia of diabetic patients. What is the adverse impact of hypoglycemia? As you mentioned, these are the effects of different types of hypoglycemia. That is the cost, and that is the work days lost. Okay? The average is loss of 3.1 productive days per episode of hypoglycemia in the UK. These are figures from UK. Unfortunately, we do not have Indian figures for this. So this is, as you mentioned, it's a rate-limiting step for letting patients achieve their targets. Severe hypoglycemia, as we can see, we'll show you in the ACCORD study, showed that it considered a marked increase of macro and microvascular events and result in morbidity, and it can have effects on patients, employers, and even insurance parties in the foreign countries. And insulin is a key predictor. So this is the ACCORD study which showed that patients who never experienced severe hypoglycemia have a much, 1/3. The patients who had severe hypoglycemia had 3 times the mortality. Remember, ACCORD was done in patients who already had complications, who had cardiac problems, and we tried to aggressively control the sugars. So if you produce hypoglycemia in them, they had 3 times the mortality. So that is also a big problem. So hypoglycemia has to be avoided at any cost. So one of the options to this is one of the guidelines, UK NICE guidelines, said that in UK they are now saying instead of adding a sulfonylurea, you should be adding a DP4 as your second line of treatment after metformin, reducing your consequences of hypoglycemia. Okay. So other problem we mentioned hypoglycemia and weight gain. Okay, so we have this term called hypoobesity. Hypoglycemia and obesity. That is called hypoobesity. So majority of the times you have seen this is overweight in Indian population. You can see between 1989 and 2003 there is a 750% increase in obesity in the rural areas. Let alone the urban area. Even in the rural areas there is a high incidence. And that has been one of the important factors to drive increasing diabetic epidemic in India. So that is from 1989 to 2003, 191% increase in incidence of type 2 diabetes. And if you remember that overweight is related to cardiac mortality, morbidity. Cardiovascular disease, coronary artery disease is more in obese patients than in non-obese patients. So weight gain, so we do not want any agent which will produce weight gain. 1 kg weight gain will increase your cardiovascular risk by 6%. 1 BMI change will increase it between 8 and 12%, depending on whether you're a man or woman. So anti-diabetic medication, which this is a summary of these available in the market. These cause weight gain. Sulfonylurea causes hypoglycemia as well. Semaglutide can cause hypoglycemia. Thiazolidine, a lot of controversy is now available with these drugs. They also cause weight gain. These are weight neutral, glucuronidase inhibitors, the DPP-4 inhibitors. Of course, weight loss is produced by diet and exercise. Metformin to some extent, but your main weight loss producing drug is your liraglutide and exenatide as the GLP-1 analog. So the weight gain from diabetic medication, two drugs create a vicious cycle. That is, we have one modifiable factor for diabetes, which is obesity, and we do not want to use a drug which will increase your obesity. So the newer agents, as you mentioned, one of them is DPP-4, are weight neutral. The GLP-1 is also a new one, which is probably going to come in the next year or two, which is weight losing, and also we have the GLP-1 analog, which is injectable, unfortunately, but produces a big amount of weight loss. So in summary, we mentioned about hypoglycemia, we mentioned about obesity, and there's a clear association between obesity and hypoglycemia and cardiovascular disease. So we need modalities with minimal hypoglycemia, drugs with weight loss or weight neutrality. So this will lead to better adherence and compliance, leading to less cardiovascular events. Remember, majority of your diabetic patients will have a cardiac event before they pass away. So what is the solution? What can be done? One of the options is using a fixed dose combination. Okay? So if you have a fixed dose combination of glimepiride, this is glyburide, which is used in foreign countries, and metformin, and adherence rate is only about half. But if you have glimepiride and metformin, the adherence rate for a fixed dose combination for the same drug was much higher than when you use the two drugs differently. And different drugs are now available in combinations, and the fixed dose therapy in anti-diabetic